Dear colleague, welcome to the fourth part in this course where we will continue with modern DBS for psychiatric conditions. As we discussed in the last lecture, modern DBS for movement disorders has been a success story. More than 230,000 patients have received DBS and more than 15,000 scientific papers have been published. The success of DBS for movement disorders created an interest in the potential of DBS for other conditions, including psychiatric disorders. And this is not surprising considering that psychiatric disorders are much more common than movement disorders and a much larger burden to society. Even if many patients will recover spontaneously or with the help of conventional therapy in the form of pharmacotherapy, psychotherapy, or electroconvulsive treatment, a substantial number of patients with severe symptoms of a long duration have therapy-resistant symptoms. They will have tried more or less everything with no or limited effect, and DBS has now been evaluated in a few of those patients, as we will discuss in this lecture. For pure psychiatric indications, the first publication of interest was the one from Barthes in 1999 on DBS in the internal capsule. Of importance was also the later publications related to STN-DBS, which came to result in DBS in the limbic STN and middle forebrain bundle. And finally, the introduction of subcingulate gyrus DBS for depression by Helen Mayberg and Andres Lozano in 2005. However, it is difficult to describe this development only from a temporal perspective, and I will therefore give a more thematic presentation. It was natural that the interest was first focused on OCD, since lesional procedures had proven most effective for this condition, and there were a number of groups performing capsulotomies for OCD around the world. Later also DBS for depression would be evaluated, and the field of psychiatric DBS has evolved to some extent by serendipitous findings during STN-DBS for Parkinson's disease, but mainly by the adaptation of known lesional targets to DBS. And let's start with that route and look first at OCD. So, regarding OCD, we have currently 8 different targets and more than 320 published cases, and it all started with simply implanting an electrode in the same place as where capsulotomies were performed. That is, in the anterior part of the internal capsule, but the effect of DBS here was not satisfying. When the location of the electrodes was analyzed, it was noticed that the effect was better further posterior in the internal capsule, while the target was moved in this direction. Some groups have chosen to target nucleus accumbens. However, it seems as if the effect in the accumbens itself is poor, and that the effect of stimulation is mostly achieved on the higher contacts located in the internal capsule. Even further posterior, in the inferior thalamic peduncle, the group of Velasco have reported good results. Between these areas is the bed nucleus of stria terminalis, suggested as a target by Barthes and now used also by my team. Recently, the group of Lozano published a report on the ITP, but 2 mm more anterior than Velasco. And this ITP target must be overlapping with the BNST target to a large extent if one looks at the location of the electrodes, and especially if one takes into consideration the size of the volume of neural activation. Considering the large VTAs, it is difficult to know what we are stimulating and what is the best target in this area, and we are probably entering the same or connected networks at different points, and the results are indeed very similar. Thus, I believe that we might have more targets for DBS in the literature than in the real world. And that when discussing the different targets, we need to realize the weakness of the terminology and to look at where we are actually stimulating. The area of the internal capsule is the most commonly used area in DBS for OCD, but let's now move away from the adaptations of old lesional targets to new targets based on serendipitous findings during STN-DBS for Parkinson's disease. Most of what is happening in a human is either originating or being perceived in the brain, and can hence potentially be affected by DBS. And DBS has provided us with a window to the human brain, and not only a window to look through, but we can reach through this window and affect what is happening on the other side. Even if our intention is to, for example, reduce tremor in Parkinson's disease, we will sometimes encounter unexpected effects. And such unexpected effects becomes more common when we are stimulating outside our intended target. A problem with DBS is that sometimes the electrodes do not end up where intended. This problem is, however, also an opportunity, since it gives us the possibility to investigate other areas of the brain. Here we have one example of such an unexpected effect, where the patient responded to GPI DBS for Parkinson's disease with acute sorrow and depression, immediately reversible on turning the stimulation off. And serendipitous findings during DBS in the subthalamic nucleus, or STN, in Parkinson's disease has been of certain importance in the development of DBS for psychiatric disorders. Sometimes we see psychiatric or so-called limbic side effects of STN DBS, such as depression or more often hypomania. The STN consists of 3 compartments, and the most anterior being the limbic part. And limbic side effects are sometimes caused by stimulation of the limbic STN, and DBS is done here for OCD. These effects occur also in the area of the medial forebrain bundle, medial to the limbic STN, which is used for DBS both for OCD and for depression. Here we have one example where stimulation of a medially placed electrode affected the limbic STN and the area medially to this, and caused hypomania at a current necessary to provide an optimal effect on the Parkinsonian symptoms. Psychiatric side effects can further appear below the STN. In this patient, stimulation below the STN caused acute severe depression with crying and death wish. But there are no strict boundaries between the different parts of the STN. And here we have another patient where stimulation of well-placed electrodes high up in the STN caused a slight hypomania, or rather mirthful laughter at low current. So it was noticed that stimulation-induced hypomania was more common when the electrode was located in or at the side of the anteromedial part of the STN. And in 2002, it was noted in 2 French Parkinsonian patients with STN DBS and concomitant OCD that stimulation improved also their obsessive-compulsive symptoms, and these electrodes had a very anteromedial location. And this led to the French multicenter study of limbic STN DBS for OCD, published in 2008. This was a blinded crossover study with 17 patients and only 3 months follow-up, and a 41% improvement on OCD according to Y-box. If you want more details on this procedure, then have a look at the lecture by Karin Karachi. Stimulation-induced hypomania in a Parkinsonian patient with an anteromedially located electrode was also analyzed by Volker Koenen. He interpreted the phenomenon based on tractography as caused by an activation of the medial forebrain bundle. Based on this, Koenen introduced the medial forebrain bundle as a target for depression and later also for OCD. This structure stretches for a long distance and is currently being targeted for OCD also far away from the area where Koenen is placing his electrodes. Regarding the limbic STN, positive effects was reported also from the group of Marwan Haris in London, and it is interesting to note that those stimulating the limbic STN seems to be very close to those stimulating the medial forebrain bundle. The report from London was a comparison between the STN and the nucleus accumbens, and the outcome of these different targets seemed to be similar, but this will be discussed in the next lecture, as well as patient selection, management and such. Let us now continue with DBS for depression, where we have about 9 different targets and 350 implanted patients. This is an estimate on the number of implanted patients and not of published patients, which is of course smaller. And the most important of these targets have a long history and have been previously used for lesional surgery for depression. And most of these targets are the same as used for DBS for OCD. This is quite natural, since the interest in DBS for depression has mainly been fueled by the knowledge that lesional surgery was sometimes effective, and since positive effects were reported on concomitant depression in patients treated with DBS for OCD. Many groups have a preferred target and will use this both for OCD and depression, and this is probably not an expression of the man with a hammer phenomenon, but simply reflecting the same situation as in movement disorders, where we can treat different disorders in the same target and the same symptoms in different targets. Depression and OCD are in the brain networks not as separated as they might be in our artificial classification of the conditions. As we discussed regarding OCD, some of these targets are more or less the same and differs more in name than in actual location of the field of stimulation. And if we limit ourselves to the targets used in more than a handful of patients, then we have basically three target areas: the medial forebrain bundle, the area of the internal capsule, and the subcallosal cingulate gyrus. The medial forebrain bundle is the third most common target. Less than 30 patients have been published, but promising effects have been demonstrated. In the largest study from 2018, 16 patients were included. Depressive symptoms were reduced with 56% after 12 months. However, this study included a randomization of half of the patients to DBS and the other half to sham stimulation, and no difference was seen between these two groups, why it might be considered as a failed study. The second most common target is the area of the internal capsule with about 70 patients. This target was chosen mainly based on the positive effects seen on concomitant depressive symptoms and anxiety in patients with OCD treated with DBS in this target. And a number of open studies demonstrated promising results, like this one by Malone with 57% symptom reduction. Unfortunately, also in this target did a randomized multicenter study of 30 patients with sham stimulation fail to demonstrate any superiority of stimulation versus sham stimulation. We then come to the most commonly used target for depression, with about 250 implanted patients, the subcallosal cingulate gyrus. And this is actually not used for OCD. This was introduced as a target for DBS by Helen Mayberg and Andres Lozano in 2005 based on PET studies. However, mostly the same area was previously targeted in the subgenual cingulotomies as well as in the subchordate tractotomy. Concerning the results, 64% were responders and 43% in remission at last follow-up after 3.5 years in this non-randomized study. Unfortunately, a multicenter randomized sham-controlled study failed to demonstrate superiority over sham stimulation. The results from the open phase were, however, better, with close to 50% response rate. And recently, Mayberg presented long-term data from 28 patients in the single-center study with quite impressive results as seen here. Further, the same group have stated that in order to identify the optimal target, the gross anatomy is not sufficient. A retrospective connectomic analysis suggested tractography targeting based on 4-bundle convergence, forceps minor, uncinate fasciculus, cingulum, and frontostriatal fibers. And this was performed in 11 patients, and after 1 year, 9 patients were responders and 6 in remission. These data does of course need to be reproduced, but it is indeed most interesting. We thus have a number of failed randomized sham-controlled studies of DBS for depression. It is of course possible that DBS in these targets does not have a good effect in depression. And here I believe that it might be necessary to point out that most of us who work in this field have seen dramatic effects of DBS in individual patients, which we would be reluctant to ascribe to a placebo effect. However, even if DBS might be effective in individual patients, this does not rule out that the effect on average at a group level might be small, insignificant, and not sufficient to motivate this as a treatment. But there might also be other explanations. The effect of DBS does often take a long time to develop in these patients, and I believe that the follow-up time was much too short. This was due to unfortunate decisions from the companies sponsoring these studies. Perhaps some electrodes were suboptimally placed when involving more centers with less experience. Perhaps there were differences in programming. and perhaps patient selection was of importance. I don't think that anyone knows for sure, but there has been some speculation regarding different effects from the different targets on different symptoms. This is not built on solid grounds, but there are some ideas that the internal capsule area might have a stronger effect on anxiety and that the subcingulate gyrus might have a stronger effect on melancholic symptoms, so the patient selection might be of importance here. We need further to realize that depression in comparison with OCD is a very heterogenic and complex network disorder rather than a dysfunction of a few specific brain regions. Several different networks are believed to be involved, and here, just as an illustration of the complexity, we have the suggested network for anhedonia. Add to this other symptoms and networks, and the complexity is, at least for me, overwhelming. Samir Chet and his group have perhaps taken this to its logical conclusion by trying to tailor the stimulation to the individual patient's brain. They implanted 4 electrodes for stimulation in the subcingulate gyrus and in the area of the internal capsule, and a further 10 electrodes for recording. They then stimulated and recorded the patient's brain during 9 days for 180 contacts and decided which pattern of brain activity was most desirable concerning the patient's condition, and then decided which stimulation parameters would create this pattern of brain activity, and then used this for chronic stimulation, which resulted in remission of symptoms after 18 weeks. Stangos et al. Implanted 10 electrodes for stimulation and recording and found that high gamma activity in the amygdala correlated with severe symptoms, and that stimulation in the area of the right internal capsule would result in a decreased gamma activity in the amygdala with a subsequent symptom reduction. They then implanted a unilateral closed-loop system where high gamma activity recorded in the amygdala would trigger stimulation in the internal capsule, and the patient went into remission after a few months. Both these case reports are most impressive, and perhaps this is the future. My only concern would be that it seems awfully complicated. DBS for depression is not an established indication for DBS, but still at an experimental level, why I will not discuss this in any more detail. However, if you would like to learn more about this subject, then please consult this lecture by Samir Chet on our webpage. OCD and depression are the most common psychiatric indications for DBS, but there are a number of studies also on other more unusual conditions. In relation to DBS for depression, generalized anxiety disorder has been mentioned in the literature. Considering that DBS has an effect on the anxiety component in both MDD and OCD, it would be interesting to study the effects in generalized anxiety disorder more closely. Unfortunately, there are no published studies, but here we see the effect in an ongoing study of BNSD-DBS, where anxiety was reduced with 53% and depressive symptoms with 66% in 3 patients at last follow-up, so it seems worth to investigate this possible indication further. Lesional procedures and early DBS has been used for addiction, among others in a large number of cases by Bechdeva. In modern times, concomitant effects on drug addiction has been reported in several patients treated for OCD, and one small case series have been published on DBS in the accumbens with positive effects in alcoholism. There is further one case report on successful DBS for heroin addiction, and a recent case series for the same indication, where 5 out of 8 patients had not relapsed after 3 years. In total, 29 patients have been published with DBS for anorexia in the subcingulate gyrus or the accumbens, with somewhat promising results. But this is a complex condition. Sometimes anorexia will be a part of OCD, sometimes it's appearing with severe depression, so there are many different factors to take into consideration. Even more difficult than anorexia is obesity, where DBS in the accumbens, lateral hypothalamus, and ventromedial hypothalamus have been published in 3 reports on a total of 5 patients with very limited success. The medial hypothalamus was Sano's target for hypothalamotomies for aggressions, and this target was rediscovered for DBS by the group of Francini, who reported a favorable outcome in 6 out of 7 patients. And positive results have also been presented by Kuhn, Torres, and others in a small number of patients. However, these are all or at least mostly patients with cognitive impairment, and I think that we should be careful with this indication. And the same is probably true regarding another rare indication, schizophrenia. It has long been discussed if DBS might be beneficial regarding some of the positive symptoms such as OCD, and there is now one study of 8 patients with schizophrenia with some positive effects reported. Finally, there is a case report on DBS using the old lesional target in the amygdala for autism. This target was also used for post-traumatic stress disorder, where a total of 3 cases have now been published. So, to conclude, DBS has revolutionized the treatment of movement disorders. Psychiatric disorders constitute a much larger cost to society than movement disorders, and there is a considerable interest in DBS and promising results, but only a few hundred patients have been published during the last 20 years. There are probably several reasons for the lack of interest. Perhaps DBS is not as effective in psychiatric disorders as in movement disorders. The result of the treatment cannot be visualized in the same manner as in movement disorders. The patient management is much more complicated, and we are still carrying the burden from the lobotomy era. However, the most important reason is that, to a large extent, the neurologists are responsible for the rapid development of DBS for movement disorders. The psychiatrists have not embraced the possibilities of DBS, and DBS will not fly if the psychiatrists are not leading the development. And with that, we end this presentation, and please have a look at the next lecture, where we will discuss DBS for obsessive-compulsive disorder in more detail. Thank you for your attention.